The scope of today's lecture is, as we already said, to present only salient features of red cell changes, causes, and significance. Hello? Are you okay? Hello? Hello?
But mbona ameita class yake blood transfusion?
Hello?
Please, sorry, Professor.
Yes.
Please continue.
All right.
Sorry.
The scope of our lecture is mainly to present the salient features of the changes, their causes and significance. We hope that at the end of the lecture, we shall be able to describe the main red blood cell changes. These, as demonstrated in the total blood count, blood film, bone marrow, and other investigations. In other words, we'll be looking at mainly the complete blood count as we may get from the cultogram. Also, what we'll see when we examine the blood film, when we examine the bone marrow and other investigations. Other investigations here will mean other corollary laboratory features that usually accompany some of these changes. And we will see the changes that we may see in biochemical analysis. For example, serum ferritin, sideroblastic changes, vitamin B12, folic acid, and other iron studies. We will also know the cause or some of the causes of the changes. We will know further investigations of such changes where necessary. We will also know anemias associated with the changes. May I describe here upfront that anemia is one of the consequences of the changes. In itself is a change. So that whenever we see these changes, they may not mean automatically that we are dealing with anemia. However, anemia is one of the consequences of the changes that we will dwell in to some depth. The main hematological parameters that we use is the total blood count. These mean white blood cell count, including differential count, red blood cell count, hemoglobin level, packed cell volume, red cell count, hemoglobin level, and the packed cell volume are usually referred to as values. From these values, we get the indices. The indices, mainly MCV in femtoliters, MCH in grams per liter. Platelet count as well will be able to know. The basis of these is that they are all related. They are perhaps more related due to the cause and also the significance of the red blood cell changes. I repeat, we require the white blood cells, we require the platelets, we require the reticulocytes in order to understand the changes, because they may reflect to us the relevance of the changes, and they are also part of the red blood cell changes. We will, on the basis of this red cell count, values, and indices. And on examination of the red cell on the blood film, three main types of red cell changes will emanate: the nomocytic or nomocytosis, microcytosis, macrocytosis. In fact, there are times when we may get a mixed picture. The mixed picture may come because there are multiple causes of the changes. There may be complications of the changes. There may be treatment, so much so that two different types of these changes may appear. In other words, we'll be talking about dimorphic. Rarely, in a biological system like the human being, would you find a clear and straightforward nomocytosis. We may find other causes other than other changes than plain nomocytosis, microcytosis, macrocytosis, or dimorphic picture. These changes generally can be divided into two main groups. They may be congenital or acquired. As we know, most of the things, most of the conditions, disease in type or normality, may be due to congenital or acquired. Causes of the features, whether they are congenital or acquired, the causes of these features may be due to the red blood cell changes, what we call the corpuscular. The red blood cell change may be intrinsic to the red cell. As we know, the red cell has got a membrane, has got a small cytoplasm, and contents such as the hemoglobin and a small battery of enzymes. When there is a change due to these changes, the red cell membrane, the hemoglobin, or the enzyme, we call that corpuscular. On the other hand, the environment in which the red blood cell is may impact on it to effect and result on the changes. We know the major environmental composition of the red blood cell are the blood vessels, the bone marrow, the spleen, the liver, the lymph nodes, or the reticuloendothelial system. We know that these impact on the changes that we may see on the red blood cells. These changes may primarily be due to the physical impact on the cell, the biochemical impact on the cell, the immunological impact on the cell, the infection on the cell. This may work again on the membrane, on the hemoglobin, on the enzyme. It may work from the primary structure, the secondary structure, the tertiary structure, and the final red blood cell, the mature red blood cell. So these changes, therefore, are a manifestation of various processes that are on the red blood cell. On the total blood counts, yeah, these changes will give us to understand the size, the shape, the internal paleness, or the density of the hemoglobin distribution on a red cell. This, of course, we have already alluded to this. So that whatever we describe as a change will be on the size, will be on the shape, will be on the central power, will be on inclusion. Of course, the changes in size, we call it anisocytosis. Changes in shape, call it poikilocytosis. Changes in central power may be hypo, normal, or polychromasian. The changes in shapes are several in time, some of which have got a significance. Inclusions also are of various types, all of which have got some significance. The major change, consequence of the change, the major consequence of the change is anemia. Anemia is a sign, it's not a diagnosis. As we know, anemia is a reduction in the level of hemoglobin for age, gender, and geographical area. We need these three parameters in order to talk about anemia. In other words, one's hemoglobin, for example, may be 12. If you're a male and you live in high altitude, that probably is anemia. If you're a female, you live in low altitude, that probably is not anemia. But we have to be careful with regards to anemia. As we said earlier, there is true anemia, which is what we are describing about, which indeed is a reduction in the hemoglobin level, which is basically sum total of reduction of red cell mass. Then we have anemia because of dilution, because of an increase in plasma volume, such as may occur in pregnancy, in cardiac failure, fluid overload, and in massive splenomegaly. As we have said, anemia obviously will manifest with all the major changes, any of the major changes. The major changes, I repeat, normocytic, macrocytic, microcytic, or mixed picture. A normocytic, which may result, is usually a cell of normal size, 7 to 8 microns in diameter. Of course, there may be minor variation, as you can see from this picture. The cells are almost the same size as a normal small nucleus of the lymphocyte. But there are minor variations, which is basically acceptable. Such condition which present with a nomocytic picture are seen in chronic diseases, in infections, in some of conditions like obesity. Indeed, some call this nomocytic anemia as anemia of stress. And as I said, may find nomocytosis, which then can progress to nomocytic anemia. Of course, we know diseases change in terms of intensity, in terms of grade, and in that case also change in terms of severity. In other words, the severe form of macrocytosis will manifest in anemia as a consequence or as a complication. Is your slide moving?
Yes, it is.
Okay. So the other one is microcytosis. Microcytosis would generally mean small cells. These small cells are seen as, can I ask Kevin Onyango and Bosibori and Cynthia Sirma to get out of the screen, please? Hello? Can I ask them to get out of the screen? Give me a minute. I don't need this. Yeah.
But nimejua mbona ndio jina langu limekuja.
There it's coming. So I wanted this one to come down.
Professor, is the screen okay now?
No, it's okay. It's okay. I'm trying to adjust it from my side. Give me
Okay.
a minute. This one should come down. First.
Namba. Wait.
Sorry about that. The macrocytosis can be seen both in the hemogram, whereby it is the MCV is less than 86 femtoliters. In that case, the MCV is reduced, MCH is also reduced. Generally speaking, macrocytosis is usually due to an abnormal hemoglobin synthesis or hemoglobin synthesis failure. It is usually due to poor or lack of incorporation of the iron, so that there is a block in iron metabolism or failure in protoporphyrins or heme synthesis, or failure of globin synthesis, or formation of crystals. I want us to take that note. Therefore, there are a variety of causes of microcytosis. Iron deficiency just being one of them. Wrong iron metabolism is another one. Failure of protoporphyrins is a third one. But by and large, the hemoglobin heme synthesis is a major cause of microcytosis. Any cause of failure of globin synthesis or formation of crystals of hemoglobin would result in microcytosis. Of course, common things occur more commonly, so we will demonstrate the commonest causes of microcytosis. This is a microcytosis due to iron deficiency. Please note, I say iron deficiency, not iron deficiency anemia. Iron deficiency anemia is a complication or a consequence of iron deficiency. In iron deficiency, the peripheral blood appearances are those of microcytes with a large pale center. Generally speaking, a pale center should not be more than 1/3 of the diameter of the cell. But when it is hypochromic, it means that there is a larger than usual pale center of the red blood cell, in addition to these cells being small or microcytes. There may be attended as well other shapes. These usually are a consequence of what the cause of the microcytosis is, of the complications, of the degree and severity of microcytosis. In other words, initially it is just microcytosis, but as the cause persists, as the cause becomes worse, there are the attendant changes, not only in the shape, but also in the inclusions. As we can see here, this is a very severe form of microcytosis. This microcytosis is accompanied by very severe hypochromasia. You may also see scattered about some poikilocytes, particularly pencil-shaped red blood cells. You can also see some teardrop-shaped red blood cells. However, please, would you be kind to us? And mute, please. As I was saying, the commonest accompanying change in shape are pencil-shaped or oval-shaped cells. These can be seen in the lower view of the peripheral blood film as illustrated. Some poikilocytes are also present as exhibited by thin, elongated, or pencil-shaped red blood cells. Also common are platelets, those that looking like deadline dots. This is a higher power view of the blood film. See some of the changes there, and some of the changes there, as I say and I repeat, involve changes in shape, changes in central power, changes in inclusion. If you check clearly, you'll see three types of changes in shape. Right, covering there, you can see an oval shaped or pencil shaped, which is bent. You can see a teardrop or pear shaped, and you can also see a target cell. These are due to the severity. These are due to the cause of microcytosis. I repeat, these are largely due to the causes of this particular microcytosis. As in the case of iron deficiency leading to microcytosis, it starts with distinct tissue iron deficiency. In other words, the iron contents in the tissues decrease. However, then there is still normal hemoglobin and normal red cell indices. In the second stage, there may be still normal hemoglobin and serum iron and total iron binding capacity. However, serum ferritin starts to go down. Stainable bone marrow iron or tissue iron start going down. Finally, there is reduced serum iron and a raised total iron binding capacity. In other words, the level of manifestation in the total blood picture, in the blood film, is a manifestation of severity. The severity is a manifestation of the stages. The iron deficiency, anemia particularly, goes in stages. Initially, it is just the low ferritin, followed by absent stainable tissue iron. Later on, serum iron goes down, total iron binding capacity goes down. Therefore, if you are to measure or to have the most sensitive way of detecting reduced iron, we would go for serum ferritin. Finally, we have low MCV and MCH on automated blood count. On the peripheral blood film, we may have now hypochromic microcytes. We will now have anemia. Other changes may now appear clinically with reduced iron in the body, particularly the epithelial changes. Generally speaking, in a straightforward iron deficiency, we do not need to do the bone marrow. However, the bone marrow may be done for stable iron in cases of differentiating the causes of microcytosis. In the bone marrow, like in the peripheral blood, the red cells present in both are small and pale. Occasional pencil-shaped target cells may be seen. There is clear anisocytosis and poikilocytosis. Accompanying this, there may be increase in platelets and a mild neutropenia. However, the changes in platelets, changes in the white cells, particularly neutrophils, are pegged on the cause of iron deficiency or microcytosis. The marrow may show increased number of red cell precursors, poor hemoglobinization, and no stable iron. Once we have demonstrated iron deficiency, we then have to demonstrate, find out the cause of iron deficiency. The causes of reduced iron deficiency may start from simple evaluation. Of course, the clinical picture of the patient can tell us, can lead us into the direction of how to investigate. Common things occur more commonly. So we start with stool for occult blood, stool for examination of ova and cysts or parasites. We may also do urinalysis for hematuria or microcytic hematuria. We may also do other blood tests to show us the functions of the kidney, of the liver, of the thyroid, because we know these are some of the conditions which may directly lead to blood loss if there is a coagulopathy, if there is varicose veins, or poor utilization of iron because of thyroid functions, which may also manifest with myxedema. In terms of parasites, we know that eosinophilia may accompany some of these parasitic infestations. We may also demonstrate the blood film picture of hyposplenism. Hyposplenism may occur in celiac disease. Celiac disease may manifest with microcytosis, target cells, and also hypochromasia. In some cases, we may do also the coagulation screen. I emphasize this will be dependent on the clinical scenario that we are having. Notwithstanding, when we are investigating the cause of microcytosis, these are the other addendum tests. Urine microscopy, we may also stain urine for hemosideruria. That is, if there is intravascular hemolysis, iron is lost in the urine. Some of these cases may present with hypomicrocytic hypochromia. There are some cases that present with microcytic hypochromia, in which case an analysis of urine is important in microcytic hypochromia. This is a picture of one of the conditions which manifest with microcytosis and hypochromic cells, sideroblastic. Sideroblastic anemia may be primary or acquired. The peripheral blood film will demonstrate microcytic hypochromia. When we are not sure, particularly if we suspect microcytic hypochromia due to sideroblastic anemia, in this case, bone marrow aspirate examination and staining for iron is relevant. This is an overall picture of the common causes of microcytosis. Common is iron deficiency, followed by hemoglobin abnormality, the thalassemia, hemoglobin abnormality, the thalassemia. Please note, this is not hemoglobinopathy, but hemoglobin abnormality. This is followed by anemia of chronic disease. Anemia of chronic disease, we look at it again. In the severer form of chronic disease, may present with microcytic hypochromic. However, early on, anemia of chronic disease manifests with normocytic normochromic. Then we have sideroblastic anemia. In other words, 4 common causes of microcytosis are iron deficiency, thalassemia, chronic disease, sideroblastic. These can be differentiated by the various parameters that are evaluated. The major parameters are MCV, MCH. These may not discriminate the causes of microcytic hypochromia. Red cells to some level may, whereby red cells tend to be increased in the thalassemias. Serum iron also may help to discriminate, but mind you, serum iron measures the amount of iron in circulation, which may not be very specific indeed. However, it is tend to be increased or even normal in thalassemia as well as in sideroblastic. Anemia of chronic disease, it is more of the cause that will determine the level of serum iron in this condition. Total iron binding capacity, again, is usually quite discriminative, but particularly if it is increased. If it is not, then it is not extremely useful because it will be normal in thalassemia and even reduced in chronic disease as well as sideroblastic anemia. The ESR, which is usually a common investigation, will suggest to us if there are any other underlying disorders. Reticulocyte count, again, can also suggest to us the associated complication, associated causes, but generally speaking, not extremely useful. Bone marrow for stainable iron, as I said, if it's a straightforward iron deficiency, it is not necessary. But if it is for differential causes, then one may do for stainable iron. It is increased in sideroblastic anemia of chronic disease, and also in thalassemia. But again, it is usually not extremely useful because of the many causes of absent stainable iron. Staining for sideroblasts. Staining for sideroblasts in the bone marrow, occasionally in the blood, peripheral blood. Staining for sideroblasts is an important study, and that is the more reason where we need to do bone marrow, particularly when we are thinking of sideroblastic anemia. In sideroblastic anemia, the type of erythroblast iron is in the form of a ring, referred to as ring sideroblast. Ring sideroblast can suggest to us not only that it is sideroblastic anemia, but also the cause of that sideroblastic anemia. Doing hemoglobin studies, particularly A2, is to try to understand the thalassemia situation. Usually, it is increased in beta thal and reduced in alpha thal, but falsely low in iron deficiency. Therefore, definitive study would be serum ferritin. Then we have a whole host of macrocytosis. Macrocytes are large cells more than the usual size of 8 microns in diameter, or an MCV of more than 96. The level of macrocytosis, the level of MCV in terms of femtoliters will reflect on the cause, reflect on the severity, reflect on the complication. The underlying defect appears generally to be biochemical. In other words, the resultant, the primary abnormality of macrocyte is a fault in the DNA synthesis. Any cause that may lead to pyrimidine or purine inhibition will lead to an abnormal DNA, and finally will lead to macrocytosis. This is important, particularly when it comes to management of the patient. Associated with any condition due to DNA changes. Just imagine due to DNA changes. In fact, in the overall, due to changes in the red cell membrane as well. Whenever we have macrocytosis, we need to differentiate into 2 major classes: megaloblastic macrocytosis, non-megaloblastic macrocytosis. From the history, from the information you get from the patient, from other investigations, it may be clear as to what is the likely cause of the macrocytosis. Here, we think of liver disease, we think of dysplasia or myelodysplasia, think of endocrine disorders, we think of abnormal erythropoiesis or dyserythropoiesis, and in some cases, such as in the neonates, in aplastic anemia, and in some anemias secondary to liver disease and to other chronic diseases. In megaloblastic macrocytosis, the peripheral blood will also manifest some of these changes. Not only the macrocytes, but also the poikilocytes. The poikilocytes here tend to be red cell fragments. There are also changes in platelets. There are also changes in the white cells, specifically the neutrophils. The neutrophil will have more than 5 segments, nuclear segments. You may know that the normal is between 3 and 4. When we have 5, if we have 6 or 7, it's almost definite we are dealing with a megaloblastic macrocytosis. As I said, look at the corner of that triangle, just at around, just inside the corner, the left-hand corner of the triangle in front of you, you will see an oval macrocyte. Oval macrocyte. And oval macrocytosis is a common finding in megaloblastic macrocytosis. So also are hypersegmented neutrophils. Now, there is, on the other side, an abnormal neutrophil with not only several segments, but also the nucleus is very big, the cell itself is very big, the granules are relatively reduced, although that may not be very obvious here. That is what we see in myelodysplasia. In myelodysplasia, as we have already seen, macrocytosis accompanies this erythropoiesis and this hemopoiesis. That this hemopoiesis affects all the cellular elements. This erythropoiesis affects mainly the red blood cell. When we are dealing with such conditions as myelodysplastic syndromes, you see the whole of the red cell, the white cell, and the platelets. They are all abnormal in one form or the other. So it is important for us to appreciate the abnormalities that may be associated with macrocytosis. I repeat, these other abnormalities that are associated with macrocytosis can lead us to know the cause, can lead us to know the complications of the cause of macrocytosis. The laboratory assessment of macrocytosis is a little bit more straightforward. With hemoglobin level, high MCV, abnormal white cell blood count, and a review of the blood film. From there, we have to separate them. Is it megaloblastic or non-megaloblastic? In which case, we should do bone marrow examination. May I repeat, bone marrow is the only place where megaloblasts are found. Megaloblasts are seen in the bone marrow. We may see some cells in the blood in certain these hemopoiesis. But when it comes to megaloblastic, megaloblasts are seen in the bone marrow. The last bullet tells us whenever we perform bone marrow, also stain for stainable iron. Not only stainable iron, but we look also for the possibility of sideroblast, also ring sideroblast. The presence, increase, or absence of sideroblast have got an important source to say that this is caused by this and that. It is a manifestation of the cause, it is a complication of the cause, and it can direct further management. In a nutshell, once we get the total blood count, hemoglobin level, red cell count, MCV, MCH, we look at the peripheral blood, we must then do bone marrow. When we get bone marrow megaloblastic, we assess the serum levels of B12 and folic acid. In tandem with that, we do reticulocyte count. Reticulocyte count in macrocytic anemias tend also to tell us the possible cause of macrocytosis. In megaloblastic macrocytosis, reticulocyte counts are usually low. In the other non-megaloblastic macrocytosis, reticulocyte counts may be variable. In addition, we may do liver function test, thyroid function test. The others will depend on the clinical situation, but these are the mandatory, and this is the mandatory process that we need to follow in examining, in investigation of a patient or a case presenting with a macrocytosis. There are various ways of measuring serum vitamin B12 and folic acid. We must be careful in which method that is used. That is the import of this particular slide. After knowing that there is reduced vitamin B12 or folic acid, we must find out why there is reduced serum vitamin B12 or folic acid. To do so, we must rule out the gastrointestinal causes of reduced serum vitamin B12 or folic acid. We do the Shilling Test. The Shilling Test tells us about the absorption of vitamin B12. You may know that the vitamin B12, which is associated with pernicious anemia, usually has a malabsorption of vitamin B12. In pernicious anemia, we have three things. One, clinically, we may have subacute combined degeneration of the spinal cord. Two, we may have gastritis. Three, we may have aclohydria, low pH in the gastric juice, or reduced gastric juice, These are found in pernicious anemia. Pernicious anemia is one of the commonest causes of low vitamin B12 deficiency. I repeat, when there is low vitamin B12 deficiency, we must discriminate first by deciding whether it is absorption which is abnormal. The absorption could be abnormal in several situations. The commonest one is in pernicious anemia. The others may be due to the abnormalities in the ileum. You may know that vitamin B12 is absorbed at the terminal ileum. If there's a disease of the terminal ileum, maybe there's removed surgically for one reason or the other. Or there's a disease such as Crohn's disease which affects the terminal ileum. There will be malabsorption of vitamin B12. So we determine the absorption of vitamin B12 first. So with the pernicious anemia, there's an increase in the percentage. Well, this is the mechanism of determining absorption of vitamin B12. In pernicious anemia, the major cause of absorption or malabsorption is the presence of antibodies to the gastric parietal cells. Gastric parietal cells do produce intrinsic factor. Intrinsic factor enhances the absorption of vitamin B12 at the terminal ileum. When there is reduced intrinsic factor as a result of antibodies, as a result of pernicious anemia, there will be megaloblastic anemia due to low serum B12. There may be other associated antibodies in autoimmune diseases. Then studies may then be performed to look at the stomach, particularly the parietal part of the stomach. Then we also follow through, look at the intestines, particularly the small intestines. Terminal iliac, also the presence or absence of diverticula. The diverticula are out pockets of the small intestine, which tends to harbor microorganisms. These do reduce the available vitamin B12 and therefore lead to malabsorption, therefore lead to deficiency of vitamin B12, and that may lead to megaloblastic, and that may lead to macrocytosis. Of course, gastric atrophy, for one reason or the other, the commonest cause of gastric atrophy is pernicious anemia. This, again, manifests as a form of macrocytosis due to megaloblastic, due to reduced B12 in the body. We follow the same process. If it can be demonstrated that the macrocytosis is due to folic acid deficiency, we must demonstrate also the cause of folic acid deficiency by following the absorption pathway or the small gut pathology. We know that jejunum is where most folic acid is absorbed. In situations such as celiac disease, jejunal biopsy may be necessary to demonstrate the presence of celiac disease. Other tests may be appropriate to look for evidence of other underlying causes. Such may be in serum immunoglobulin A. This is sometimes found increase in celiac disease. It may be found in certain immunoglobulin abnormalities which lead to malabsorption. So, again, investigations of macrocytosis with normoblastic bone marrow. In other words, non-megaloblastic macrocytosis. Here, the bone marrow may give us the clue as to what is causing macrocytosis. Early forms of sideroblastic, hypoplasia, red cell aplasia, aplastic anemia, liver disease, thyroid disease, all may lead to macrocytosis non-megaloblastic. It is important for us to do this test as discriminatory or as differential for causes of macrocytosis. Good. Thank you. I said it would be quick and fast. Questions, please. Hello? 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 Are you there? Hello? Questions? Yeah. Questions, please, if any. Do you have any questions? Okay, thank you. Yeah, if you think of a question, please, you can post them later. Or you can come to me directly. These slides are available to you from the secretary. You have a question, sir?
There's a question in the chat box.
Oh, let me look. Oh, there are three actually. Can you kindly explain how dysphagia comes about in microcytic anemia? Right. In some forms of iron deficiency or very severe iron deficiency, there is what we call a oropharyngeal web. Oropharyngeal web may cause odynophagia or pain when swallowing. We call this, when there is an oropharyngeal web and there is also iron deficiency, we call that Kelly-Patterson syndrome. Kelly-Patterson syndrome. Yes, that is almost diagnostic of severe iron deficiency. It is a complication of iron deficiency. Kelly-Patterson syndrome characterized by oropharyngeal web. Oropharyngeal web obstructs things which are being swallowed, which may cause dysphagia or odynophagia. Thank you for the question. Right. How do you differentiate pernicious anemia from megaloblastic anemia? Pernicious anemia is a form of megaloblastic anemia which is characterized by the presence of subacute combined degeneration of the spinal cord, acrohydria, chronic gastritis, or atrophic gastritis. It is usually an autoimmune disease, and the autoantibodies are directed at the parietal cells in the stomach. The other causes of megaloblastic may be straightforward, reduced intake of foods which have low vitamin B12, such as may occur in vegans or people who do not eat meat. The other causes may be due to anatomical abnormality, which may be due to surgical removal of part of the stomach, surgical removal of the ileum, surgical removal of the terminal ileum. These are straightforward megaloblastic due to malabsorption or lack of vitamin B12, not due to antibodies as we found in pernicious anemia. Thank you again for the question. How can lead poisoning cause microcytosis? Lead poisoning, as the word goes, poisons protoporphyrins. And once protoporphyrins are destroyed, they do not allow for the synthesis of hemoglobin, where iron is incorporated into the heme. Iron is not incorporated into the heme to make hemoglobin. Kelly Patterson was a name. Plummer Vincent were also two people. They describe the same thing at the same time. So some people like Kelly Patterson. Some people say Kelly, Plummer, Vinson syndrome. All mean the same thing. Thank you so much. Yes, is Kelly Patterson syndrome and Plummer Vinson syndrome the same? Yes. Right? Any others? Any other questions? Yes, thank you. How is thalassemia not a hemoglobinopathy? A hemoglobinopathy is when there is a structural
Recording stopped.
Hello? Hello? Hello?
Yes, we can hear you.
Oh, yes, okay. Hemoglobinopathy is when there is a structural abnormality in one of the hemoglobin chains, B chain, alpha chain, or beta chain. However, thalassemia is a reduction in the production of the chain. It may be a reduction in the beta chain in beta thalassemia, alpha chain in alpha thalassemia, gamma chain in gamma thalassemia, and so on. However, the chain itself is normal. That is where we differentiate between hemoglobin abnormality and hemoglobinopathy. Any clearer, sir? Joshua? Yes, thank you. Yes, more questions are coming, please. In the Shilling test, what percentage do you use to assess absorption? There are different percentages on different texts. Yes, it is a discriminatory test. It is not a qualitative test. In fact, these days it is hardly done. But in a class, we have to mention that Shilling test is a test for the absorption of vitamin B12 to find out if there is an abnormality with absorption of B12. Yes, it is true, they may vary from 1% to the other, but we simply want to say is the cause of low serum B12 due to absorption or not. Shilling test answers that. I'm in the lecture. Okay, thank you. If you think of any other question, please do ask. Thank you so much for attending and being attentive. From the way you have asked questions, I'm very happy about the response. Thank you.